For those of you who don't know me, I'm Helen Schneider. I'm from the School of Public Health at the University of the Western Cape. And we are convening this network called the SA Learning Alliance on District Health Systems, just to tell you briefly about who we are before we go on to the webinar itself. We're a still relatively loose national network. There are about 25 of us that meet regularly, established about a year ago by Health Policy and Systems Researcher Collective. And we've been engaging regularly over the last year as there have been important policy and system developments happening nationally. So this collective is made up of decision makers, managers, implementers across spheres of government, and health policy and systems researchers from higher education institutions also across the country, and partners such as CHAI. Our purpose at this stage is very much knowledge sharing and networking on the district health system. We've had a series of workshops and meetings. We've considered research, capacity strengthening priorities, subnational bottom-up health system strengthening through partnerships. And that is evolving into a number of outputs, if you like. We are launching very soon a series in the South African Medical Journal on district health systems experiences and research. We're also going to be hosting more webinars and a listserv. In the long term, our interest is really how to strengthen the district health system through bottom-up national, subnational learning partnerships between these different players. So in the course of our conversations over the last year, and in particular after the Treasury instructions on cost containment and budget cuts that appeared to already begin to have impacts in the current financial year, members of this collective increasingly started to raise concerns over the impending budget cuts and the implications for them at a district level in particular. And so we had an initial discussion at the PASA conference last month, where we agreed that we would share information, international experiences, what was emerging as documentation and responses in South Africa, and in particular how provinces and were responding to the need to contain costs, and how people were experiencing impacts at really at the front line of the system. And of course, we know there's been a huge amount of media coverage and a whole lot of civil society engagement in these questions. So we decided that it would be a good moment to actually have a follow-up discussion on this. And we invited a wider cross-section of people. So normally we would have a bi-monthly update on this, the SALAD network. But we decided that we would extend the invite to a slightly wider group of people without necessarily making it totally public, and ask people to share what they thought were some of the questions for them. So these are some of the key questions that people are grappling with. So are we on a fiscal cliff or not? And clearly there's a lot of debate on that. But importantly, how do we protect the health sector in all of these processes? A concern expressed also by the Minister of Health and many others within the system, and referred to by someone as how do we shape the austerity narrative? And that's really about how do we prevent the pie from shrinking or shrinking too far. But if that pie is going to shrink, and everyone anticipates that it will, how do we think about resource allocation and priority setting within that minimizes harm, recognizing that harm will happen, and that considers the people, not just the patients, the users, the communities, but also the frontline providers who are at the coalface of absorbing impacts. And then finally, what is our role as a collective in this? So we've then decided to host this webinar, and this is what the program looks like. We're going to be running it in 2 parts, and we have 3 speakers. So in the first part, it's really setting the context, the macro picture, and trying to understand what is the overall national picture and how to think about it. We're going to be the first person who's going to introduce this is Thokozile Madonko, who is a researcher from the Wits Southern Center for Inequality Studies. She's the manager of the Public Economy Project, an economist with a lot of experience in researching and thinking around budget questions. So she's going to give, I think, largely a civil society perspective. And then Mark Blecher has very kindly also agreed to give us his views and maybe some of the detailed numbers that he probably is best placed nationally to talk about. Mark is the Chief Director of Health and Social Development in the Treasury. And then we're going to pause and invite you to comment and ask questions. And feel free to type in the chat. In the meantime, we'll monitor that. Then in the second part of the webinar for the second half, we are going to then turn to the local experience. And to get us going, we've got a very experienced district health system manager, Kathryn Grammer, who's for more than a decade been managing one of the substructures in the Cape Metro, so complex urban environment, and has been, of course, navigating austerity for many years. This isn't, a new thing. But so we'll reflect a bit on how she thinks about navigating this terrain, but also what she sees as emerging impacts, very importantly. And this then we hope will be then the springboard for others in this collective to also share their experiences and thoughts. And then finally, Uta Lehmann, who's the director of the School of Public Health here, will give some of her summary reflections and what she thinks may be the way forward for advancing this, particularly for the Salad Collective. So I am now going to stop sharing, and I'm going to immediately invite Thoko to share her slides. And while they come on, so each of these 3 people could talk for an hour each, easily. They are experts in their own right. But we've asked them to speak briefly for 10 minutes. And they've all promised to try and do that. So after the 10 minutes, I'm going to put my video on so the speakers know that it's time to wrap up, so we can leave enough time for discussion and debate. So thanks very much to you, Thoko, and over to you.
Hi, can you hear me?
Yes, we can hear you fine.
I'm just going to go. For some reason, the video I'm having tech problems today. But can you see my screen?
We can see your screen clearly.
Okay. All right. Okay, Zoom has crashed on me. I'm just going to stop the share. Try and start. I'm really sorry about this. I think Mark might have to go first because my program is crashing.
So do you want to exit and come back in again?
I'll have to exit and re-enter. Sorry,
it's fine. And we can also share your slides our side, Thoko, if that's easier. So Mark, I don't know if you can share screen, because I think if you do that, that will immediately take Thoko's down. Okay. Mark, are you able to?
It's just saying I can't share while another participant is sharing.
Yeah. So is that off now?
Yes.
Okay, I think it's okay now.
Yeah.
Okay. Can you see this, by the way?
We can see very well and we can hear you. Yeah, thanks,
Okay.
Mark.
Okay. Good afternoon, colleagues. I'm going to try and talk very quickly. I hadn't meant to show slides because I don't really have much time, but I just thought as I was putting my few points together, there maybe are one or two numbers that may be worth showing. So just by way of introduction, let me just make 2 points, just to say that I'm technically not allowed to speak about the medium-term budget policy statement, which our Minister of Finance releases on the 1st. So I'll not do that. And also just to say that the Treasury doesn't usually use the word austerity. I mean, it talks about things like budget reductions and others. So I'll probably try and avoid that in keeping with where I work.
Sorry to interrupt, Mark. You're coming in and out quite a lot, so I don't know if you can stay close to the mic or...
Okay, is that better?
Yeah, it's good.
All right, so let me say right away that I am very worried about the budget reductions, and they've perhaps been in three main parts. The first part was after COVID in budget 21. There was a big concern in the Treasury that the fiscal crisis that followed COVID had severely impacted the public fiscus. So large and escalating cuts were made in budget 21, which increased over the year. So they were quite substantial in the outer year, which is budget 2023, which is this year. And then in the current year, we had the problem of the unfunded wage increase. And then we have further budget cuts coming next year. So the combination of those three together has been extremely worrying also to me from the National Treasury side. Just looking at the numbers on this particular slide, you can see in the provincial budgets, there are 5 main primary care sub-programs: district management, clinics, community health centers, community-based. And the total together add up to about 50 billion last year, about 48 billion this year. And then we have this very large HIV/AIDS sub-program, which if you add that and nutrition together, we have about a 70 billion primary care program, if I can call it that, if you exclude the district hospitals. But what you can see here is there is definitely in the published budgets of budget 23 a fairly substantial reduction in that budget, from about 78 billion to about 75 billion. And I should just point out, though, that in the mid-year budget, it turns out most of the wage agreement is actually going to be funded, about 77% of it. So there will be additions, about 6-7 billion in the adjustment budget. And also some of the historical numbers, for example, in the HIV/AIDS program, include some of the COVID expenditure. So those two partly explain the reduction, but there is nevertheless a substantial reduction in budget 2023. All right. Now, if there is a budget reduction and one does what one can to try to address it from a funding side, one also needs to try and address it from an efficiency side. So let me go through a couple of things that have been a bit of concern to us. So if I could just show on some other slides. So the first thing is that there has been a massive drop-off in primary care workloads from what was about 130 million visits a year to around 119 million visits a year for 3 years. And that dropped off in COVID to 95 million visits, 101 million visits. It's come back in 22-23 to 106 million visits, but we're still fairly substantially below the baseline. So yes, there has been a drop in budgets, but there has been a big drop also in workloads. If you look at this per capita, around about 2012, we were at about 3 visits per uninsured. And at that time, we used to talk in the planning models about the public sector going up to 3.5 visits per capita. Now, even before COVID, this has declined from 3 visits per capita down to to 2.4 visits, and it dropped in COVID to 1.9. Since recovered to 2.1, but the full nature of the reason for this reduction, when we were thinking it was going to increase, is not fully understood. But the combined effect of what was an increasing budget over time, along with a reducing headcounts, led to a real increase in unit cost from 324 Rand to 395 before COVID, and then a leap in COVID up to over 500 Rand, back down to 478 in real terms in 22-23. So we are running at substantially higher real unit costs. All right. Now, it is true that the use of headcounts alone is a bit misleading because there's a more complex mix of outputs here. And while the primary care visits at clinics, for example, have declined from this 119 million to 100 million, that CCMDD visits have come from virtually nowhere to about 11 million visits a year. So there's been a substitution away from clinic-based visits to CCMDD visits, and that's got quite a bit of implications. And given that the CCMD visits are cheaper, should we not do more of those? There are a lot of interesting things to do with that, but also very interesting trends around community health workers and school health services, which add to the complexity of the picture. So because I'm time limited, I'm not going to talk about those now. I'm not going to show any more slides.
So you're fading, Mark? You're fading again?
Okay. So I'm not going to show any more slides, but a couple of questions from my side for people to consider, given the reducing budgets. Firstly, is this not the time for greater integration of the vertically funded HIV funding stream? I showed you on the funding slide that the primary care funding stream is about 50 billion and the HIV funding stream about 30 billion. Together, they're around 80 billion. Should they not come together in a single integrated primary funding stream? Given this time of very tight budgets. Secondly, if you look at what's in the NHI bill, the NHI bill is suggesting that we set up about 54 government components for primary health care to run primary care. So 54 new national organizations with primary care, it seems largely shifting to a national function. Should we be doing that, given this time where we are in the fiscal position? I mean, given where we are with these budget numbers, do we want to spend money right now on establishing 54 new district components at national level? Given the shift from clinic-based visits to CCMDD, what should happen with that shift? Should it increase more given the lower unit costs, or what should happen? The issue on compensation is very important because posts are substantially at risk at this time. There could potentially be a downsizing of up to 15,000 health posts in the next year or two. So that's an area of great concern. But not only has there been pressure on posts, there's pressure on goods and services. And what can be done about that? So, for example, whereas there are good cross-provincial tenders for medicines, many of the medical supplies are not bought through those kinds of tenders, and a lot of provinces spend a lot on those items and even purchase corruptly on some of those items. So what can be done on those supply items? It's been very positive to see the cheaper HIV tenders and the vaccine tenders, which helps partly. So given my limited time, I'm going to stop there. But I've tried to convey some of the points that were uppermost on my own mind. Back to you, Chair.
Wonderful. Thanks very much, Mark. And you've went 1 minute below 10 minutes. That's very impressive. So, okay, so the kind of combination of factors creating a perfect storm, or however one wants to frame it, of wage increases post-COVID, a decrease in expenditure and the revenue shortfall, but raising a whole lot of questions around potential areas for thinking about efficiency gains, integration of HIV funding, perhaps other programs too, whether we should be establishing new organizations nationally, how to maximize the potential of initiatives such as CCMDD, and then thinking about efficiencies in goods and services. So Thoko, are you back with us? Are you able to show your slides?
I'm back, and Carissa is going to show my slides so we can avoid any potential, given that today it's definitely technology is not on my side today.
But we can hear you perfectly, so that's all that counts. Yeah.
Great.
Yeah.
Okay, so I'm not even going to put my camera on just to keep everything safe. You can go to the next slide. So I caught just the tail end of Mark's presentation, and I think his provocations are absolutely critical around the way in which we think about fiscal policy and social policy as well, and how those two come together. But this is in the backdrop of just, I wanted to highlight that the budget and policy at the moment seem to be in very polar opposite positions in terms of our research, and I'll share our paper on fiscal policy and spending choices in the chat for those of you that will be interested. And what we've seen through our research is that we have the executive and government speaking quite openly about these budget cuts that are taking place, and that this is negatively impacting service delivery. We've seen the big uproar around the communication on the part of Treasury to think about budget cost containment measures. And this has had another kind of round of questions around the credibility of both the budget to deliver, but also of policy to deliver, because we have NHI in the background. We have other policy questions that Mark has highlighted that we need to be thinking about. Next slide, please. So I want to have you to have in the background of your minds this question about the budget and policy. And one of when we're talking about fiscal policy and this term that's thrown around, fiscal consolidation, which is also known as austerity, and it has a lot of, it needs to be demystified in some ways and kind of really stripped down. It is defined as legal policy changes which aim to lower public expenditure and tame growing sovereign debt burdens. And that's pretty much what has been happening. What we've seen over time, that there's been this attempt to really bring down government spending, lower public expenditure, to bring about primary surpluses. And it can vary. The way in which this is implemented can vary. And the four most common ways of doing this are public expenditure cuts, which is South Africa's main part. We're seeing massive expenditure cuts taking place, and we've seen the wage bill being the kind of main driver of bringing down costs, which is now creating concerns around the wage agreements that have been taking place. We've also seen regressive tax changes. This can be, this is my position, not necessarily the centre's position, but one could argue the increase in VAT recently by 1 percentage point, decrease in corporate income tax is another form of fiscal consolidation. So again, it raises questions about who has to bear the burden of these measures. Then you have labor market reforms and pension reforms, and that can be in the form of reducing the pension age, or increasing the pension age, reducing certain labor market benefits, for example, unemployment funds, for example. And we've seen a little bit of that, but not so much in South Africa. So the bulk, one could argue, is the first two measures, public expenditure cuts and regressive tax changes. But it is important to note, as Mark has also alluded to, that not all fiscal constrictions are inherently harmful. So we do want to cut truly wasteful public spending. and that this can provide much needed revenue for social services. So being able to bring down the cost of HIV drugs is absolutely essential. We need to be able to look and see, are we spending correctly? Are there efficiency gains? Are we being productive? Are there certain programs and projects that can be cut? So it mustn't be that we think that no expenditure constrictions should take place, but what we do have to question is the overall public expenditure cuts that are taking place. And one of the ways that we can assess this is through the outcomes, the policy efforts, the resources, and the assessment. So this is really to be able to say, are these measures having an impact on realizing people's human rights? Are they suitable to that end? And are there other alternatives available? And this is where civil society is coming in quite strongly. For example, the IEJ or the Budget Justice and the Institute for Economic Justice, the Budget Justice Coalition, they've come in and said, actually, the fiscal consolidation measures are not realizing people's human rights because they're actually having a negative impact on social services. Please, next slide. So what the research is beginning to tell us is that it's important to note that every year the budget gives concrete numerical form to policy goals. So if our policy goal is to provide district health services, we want to be able to see that in the rands and cents. And it shows citizens the choices government is making about investments and the provisions of services. So it enables government departments to plan to use these resources effectively, not as a typo. So essentially, if you do not budget for an increase in compensation of employee costs, that then has two impacts. One, you begin to question the credibility of the budget that's being presented, or you are going to begin to ask some questions about the stability of the provision of social services if you're going to hit those that deliver the services, for example, in terms of bringing their real wages down. So these spending choices and how they are financed have direct consequences for the welfare of citizens and the distribution of income. And I want to keep that in the back of your mind. When we're talking about fiscal consolidation, there are winners and there are losers. And who are the winners and who are the losers? And who is being asked to bear the brunt of these decisions that are being made? So again, it comes to the policy priorities within health. For example, if NHI is truly a priority and we start investing in building new hospitals, but we are cutting in terms of health staff, and I think Mark said something about 15,000 health personnel downsizing, you've got to ask some questions about the rationality of what's happening between the budget and policy. So we've also seen that austerity has social and economic effects, and they intersect with deepening political inequalities. I don't need to describe the nature of inequality in South Africa and the rising service delivery protests, the strikes. We've seen quite a lot of instability. It also induces severe economic costs through lowering GDP, and this is the more contested and interesting space, is whether or not fiscal consolidation brings about growth. Are we really going to see growth? It might deliver on, in the short term, around our debt portfolio or our debt prospects, but in the long run, does it damage or hurt growth? And are there political costs of economic downturns are often are considerable when you start implementing austerity-driven recessions, and it increases distrust in the political environment. And that's kind of where we're at the moment. It's quite difficult to trust what we're reading because we are in a low growth. We are in a low growth environment. Our economy is being hit, but this is being amplified by austerity-driven projects. And there's some more examples there that it's important to show that essentially there's major questioning of the efficacy of consolidation overall. Next slide, please. So austerity in South Africa, I wanted to just very quickly highlight the coming from the medium-term expenditure framework, the guidelines that sets out the preparations for the medium-term budget policy statement and leads into the budget for February next year. And essentially, this is our fiscal policy. This will stop the trend of debt service costs crowding out the budget for service delivery spending. In the short term, government will continue to strike a delicate balance between mitigating the negative impacts of COVID-19 pandemic, the recent floods in KwaZulu-Natal, Eastern Cape, while restoring the health of the public finances and supporting economic growth. So there we have to question whether or not over the medium term, this will happen. And so just to show that in terms of priorities, debt service costs are the main priority over the medium-term expenditure framework, with the largest policy function being basic education, social protection, mainly grants, and community development next, and then health is the 5th largest policy function. Next slide, please. So consolidation is focused on core public services, and basic education, healthcare, and criminal justice face the double burden of fiscal consolidation. And we're seeing this in relation to the annual average growth, of spending growth by function. Defense is under severe pressure, while we see an increase in water infrastructure and roads. Social protection is mainly grants. It's not the social welfare component, so it's important to split those out. And local equitable share has seen some growth. But essentially, the main thing to note there is that it is basic education, healthcare, and criminal justice that have taken the major hit in relation to the fiscal consolidation project currently underway, if it's implemented, if they implement it. Next slide, and then I'm almost done. So the reason why we say if is that the continuous austerity over the last decade has eroded the quality and value of public services on which the majority of South Africans rely. And most of you that are working at district health, at the district health level, maybe can speak to how you've experienced this. And there have been spending cutbacks have been intensified, with pay increases for government employees held well below the rates of inflation, and across the board spending reductions, cutting deeply into healthcare, basic education, criminal justice, and social services. And so what we're also saying is that even after these painful efforts to stabilize the public finances, the goal of debt stabilization, which is feeding the fiscal consolidation project, is unlikely to be achieved because we're in a low growth environment and because we're seeing inflation and all sorts of other kind of shocks that have come into play that are affecting the current economic environment. And then this should be my last slide. And I'll be done. Yeah. So conclusion. So just to answer some of the questions, what needs to happen? So partly what we will argue is that this very wide gap between government fiscal program and its policy agenda needs to be addressed. And I think that's what Mark was saying. We need to look internally at health and ask questions about how we want to deliver health services and how we finance it. What are our priorities and how do we then finance for those priorities? This means grappling with questions of program design, as I've mentioned. And we really strongly argue that the central fiscal problem is not expenditure, but economic growth. And so further expenditure cuts are likely to have further negative consequences, placing the full burden of macroeconomic adjustment on the middle class, i.e. government workers and the poor. So we're arguing that those that are currently, and you're working at district health level, are likely to be the ones carrying the burden. And without sustained accelerated growth, further budget cuts will only mean more austerity. So over the longer term, it's not clear how much further and how much longer spending growth can be curtailed without aggravating South Africa's deep political fissures leading to social unrest. So this is again important, which the research is showing is that fiscal consolidation programs that take place without adequate policy alignment can create political unrest and undermine credibility. And I'll leave it there. Thank you.
Yeah, thanks very much, Thoko. And you were slightly over time, but Mark saved us time. So
I stole Mark's 1 minute.
Yes, and I hope we can share your slides, Mark and Torkel, with
Yes.
we're recording this session, by the way, lots of very useful information. And for asking the fundamental questions about whether the theory of change, if you like, around cost containment actually does work in the long run, but also for providing a way of thinking about the alignment between the need for efficiencies and cost containment and policy choices, and the idea of winners and losers, and why health and basic education should be at the center of this is interesting. So thanks very much, both of you. So we've got a bit of time for discussion now. So I noticed, Erica, that you've posted 2 salient questions, and maybe we could start there, and then let's get some hands or people in the chat, and then we can take a few rounds. So Erica asks whether, if corruption could be eliminated, what would be the financial position? And that does raise, I think, an efficiency question of how you protect, particularly in the health sector, how you create more of a firewall between political and administrative decision making. I think people would point to that as a particular problem. So maybe Mark, you might want to think about that, or Toko, and then, you know, that these efficiencies, the cuts that happen, particularly in staffing, often are very blunt and actually don't really serve their purpose and worsen the situation on the ground, and managers protect their own positions. So either Toko or Mark, do you want to speak to that? And in the meantime, anybody else can raise their hands. Jenny, I see you. Mark, do you have a thought on the corruption issue?
Look, on the staff numbers issue, I mean, I think it's useful to you know, look at the actual numbers.
Can you come closer, Mark? Yeah.
I think it's useful to look at the actual trends in you know, numbers by category over time. You know, if I had more time, I would show a slide with that. The last numbers we've drawn are about 2 months back, and at that stage, the sector has kind of still fared fairly well after COVID. There are about 326,000 employees across the 9 provinces, and I think it was end of August or so when we last drew. But I think there are substantial risks going forward. It's difficult to comment in detail about the management categories, although one can pull out a certain number of them from the personnel numbers. But I mean, I take the point that Eric is making. On corruption, I mean, it's, you know, I mean, although WHO, for example, gives rough numbers that they think they see across countries, it's difficult to give exact estimates. But I mean, I think all of us, you know, would have been really horrified by, for example, the stories around the assassination of the whistleblower Babita in Gauteng, and the time it's taken for that province to get on top of that, that problem. And so, although perhaps medicines is the biggest area within goods, and most of that is through transversal tenders, as I was saying, there are a lot of goods items that are not going through those transversal tenders, where individual institutions are purchasing, and some of that is being bought at very expensive rates. So I think the more those things can move into more, not to say that some local flexibility is not important, but sometimes that local flexibility leads to things being bought at very high rates. So there definitely are, is potentially a couple of billion savings, I would say, in that goods and services procurement space that could be that could be potentially achieved.
Okay, thanks, Mark. Jenny, do you want to ask your question and then talk, or maybe you want to also think of some responses?
Good afternoon, colleagues, and thank you very much to the speakers. It's really, I'm a clinician. I'm working in the Eastern Cape, and obviously we are struggling with these issues. So I don't think I've got a real question. More just a comment, just to say, I think this is an opportunity. Someone once said, "Never let a good crisis go to waste." And I sort of have a sense that we've got to radically change the way we do things. We've sort of just been doing things, And so my first sort of observation, perhaps coming from the Eastern Cape, is that we inherited 3 health administrations post 1994, and there hasn't really been good rationalization. So in some of the smaller little towns that were the Cape, you obviously had, sort of facilities for whites, non-whites, etc. And I'm sure there are examples in other places as well. And so I think perhaps we need to look at and really look hard at how our beds are being used, and look at rationalization and make sure that the work where the people are where the work is, which obviously has lots of organized labor issues. The other thing that was very interesting, and I'm not too sure if our experts have seen any data, but I saw a presentation last week by Discovery, and they've obviously were analyzing their 2.2 million members and the impact that mental health has on function, claims. And if you extrapolate that to an insured population, we can see the huge tsunami that we're facing. And I'm just wondering whether we need to try and at supporting community mental health, perhaps using some of our smaller hospitals or CHCs, which have low BURs, and try and get more ground sort of grass support, because I think in the long run we're actually going to save. If we invest in community mental health, we're going to save in terms of work days and all the fancy economic terms, the dailies and the things, and it also impacts adherence, etc. So I think this is an opportunity to perhaps invest now, because I think the long-term benefits will surely come through economically. And then the other interesting observation coming from a meeting was, National had said we need to start ensuring that the CEOs are appointed in a much more transparent manner. And one of the suggestions was to get academics more involved in appointments, and try and cut out provincial people. And maybe that's something that we can also perhaps look at, so that I think it goes back to Eric's question, sort of corruption. If you start looking at CEOs and the power that they have, especially in terms of some services, and then just the question that was posed at the beginning around whether we should combine the HIV and the clinic, I think it was a clinic budget. There's a lot of concern around the NCD program, that there's budget for that, and the NCDs have got a huge impact on our morbidity, not so much, and mortality. And maybe that would be a good way to go, especially since a lot of those patients are benefiting from CCMDD.
Thanks, Jenny.
Because I think
yeah.
Fine.
Are you done? Sorry, I thought you were done.
Yes, I'm done.
Thanks, Jenny. Yeah, all great points. So, and then in the chat, so you're talking about ways of doing things very differently within the sector. Some of it, like open appointments, might be wider public service kind of initiatives. And then both Krish and others, Lucy and others, have pointed to the cross-sectoral dimensions of this. So what happens between Treasury and Health around negotiating of policy priorities, for example, and how to limit the harm and to keep a focus on the goals. There's also the possibility of thinking much more intersectorally about around prevention and addressing the social determinants of health. So new paradigms of of collaborative governance and joint planning. And maybe the district development model is one way of thinking about that going forward. So thanks. Thoko, just any rejoinders from you before we move on?
Yes, I just wanted to add, I think the question around corruption is an excellent one because it's a question around revenue raising, right? So we want to look at where the opportunities are for raising revenue, and corruption, of course, is one of the mechanisms that affects the ability of resources being directed towards those that need it the most. And so that actually asks us to ask some questions about our prosecuting authorities, our investigative abilities, SARS, for example, illicit financial flows, which is huge loss of income every year to misinvoicing and sort of basically badly behaving corporates. And so there is a focus, and I think it is important that we do not lose sight of saying, where can we raise the revenue? Where are the gaps? And how can we do this? And that means investing in our policing and criminal investigating capacities as well. So we want to see our National Prosecuting Authority really have the muscle to be able to take on other oversight bodies. So I just wanted to emphasize that's an important area of work, and we should not lose sight of it. The other thing I think around this question of, does I think it was does the health sector and Treasury discuss macro choices? And this, we've argued that that policy choices, that any fiscal consolidation needs to be backed by policy choices that protect frontline services. So we're not saying no fiscal consolidation at all. We're just saying the current setup is hurting health, for example. And that then requires a greater credibility and considering the way in which we engage and reforming our fiscal institutions. So how we engage on policy issues, in what way do we come to a point where we can agree that this is the kind of consolidation that needs to take place, and this is the policy that will complement it. So we've been using the example of defense, that defense has been severely underfunded. Now, I'm not for funding defense as I'm a pacifist. But if we want to increase our ability of our army to intervene in times of crises like floods, then we need to be saying this is our policy priority and therefore we need to fund it so that they're able to do it. But we come to a point where there's flooding and we ask for the army to come in and they don't have the resources to be able to do so because we haven't funded for it. So as a kind of basic example of that disconnect. And so we really want to think about the current collective bargaining and aligning that with our budget processes. So we've seen this disconnect this year with the budget being tabled with as if there would be no increase, a real increase, and then the real increase came, and then now we're told we're in a crisis. So some alignment needs to take place around our centralized bargaining and budget and planning processes in order to give more credibility to the budget. Yeah. Okay.
Thanks. Thanks very much, Thoko and Mark and all of you. Really interesting. So let's go on now to Kathy, who's going to give us a perspective from her role as a district manager and how she's worked with everyday efficiency. So, and what are the possibilities and limits of from where she sits? So Kathy, are you going to project your slides or is Carissa going to do it?
Good afternoon, everyone. I hope you can hear me. I'm not too sure if I'm able to project. Can everybody see it?
We can hear you fine.
Yeah.
There doesn't seem to be anything sort of emerging, loading. Okay. Yeah.
I'm trying to find the presentation on the Zoom format. I'm not familiar very much with Zoom, but maybe I can get Carissa to do it, and I'll say move. Thank you.
Okay.
Okay. So while Chris is just loading a slide, it's the second presentation I sent to her. Yeah. I just thought I'd have share some disclaimers with the audience. The world that I'm familiar with is for the last 15 years has been a metro-based, very urbanized environment, coordinating operations across. You can move the first slide, thanks. It's a world with multiple hospitals. We've got 6 emergency centers. We've got 5 obstetric units located across hospitals and 24/7 community health centers. 5 hospitals total, over 800 beds across specialized TB and acute district care, 2,000 staff and 1.7 billion operational budget distributed across delegated budget holders. Latest data shows that there are about 1.3 million residents in the 2 sub-districts with over 85% uninsured and growing profile. It's an urbanized environment with a commuter population coming in to work across multiple zones and also accessing health services. So I sit in the middle of a large organization, Western Cape Health Department. We get very clear directives in terms of policy and the governance roles. We, for 2023, got told to balance the budget from our district office, and we try and contextualize and customize the strategies at the levels that we are at. So the structure of the health system over the last 20 years has undergone 3 phases of transformation. So 90% of patient headcount is at primary healthcare, district and TB hospitals and community-based services, with 8% patient contact at regional general specialist level. There are general specialists also in our large district hospitals, and about 2 to 3% at tertiary quaternary services located at central office hospitals. Next slide, thanks. So just briefly, listening to the brief, I tried to compress a wide array of thoughts of our reality through the lenses of fiscal discipline or austerity, whatever official term we are dealing with, also with a post-COVID year 2 of recovery lens, because I think there's very much a forgetfulness around that we're still rebuilding multiple parts of the system and governance and services, and also just to put it through a decentralized district management perspective. So I'll just touch on some of these aspects: people management, leadership, governance, and team strategy, the service impact, and the risks and the client experience. Thanks. Next slide. So when the messages started flying around that 2023 was going to be really the crunch year, it wasn't absolutely new news. We kind of knew this was coming last year, but I think the message landed very hard quite quickly. And thinking around what our response was, I've almost blurred out other fiscal austerity experiences of 2015-16. It's kind of in the distance, but I suspect I did similar things. There was early and fast and open communication to build shared understanding of the severity and the potential impacts. You have to cascade that rapidly. Thanks to teams and governance platforms, we could do that, so that we really tried to get into the services, into the hospital and primary healthcare settings, as well as the corporate and clinical services governance structures that we've set up over the years. you literally have to listen to the fears and anxieties of managers, clinicians, ordinary staff who are grappling with what's to come, because there was a lot of guilt around. I remember being asked this question, do we have to feel guilty that we got a wage increase? Around this, I said, look, we don't feel guilty, we don't feel ashamed. You work, you do what is required of you in your space every day to provide value to clients, to provide value to your colleagues, and do the work to the best of your ability. There's zero need to feel guilty, but there was a lot of turmoil and anxiety around what this meant, and a lot of the messaging was around the stages of grief that everybody was feeling, that's familiar with. But you need to actually translate those emotions into directed action and thinking. So once the emotions have subsided, people started getting into gear, and we did this as a regular check-in across multiple platforms so that we could really focus energies around this. Because if we didn't do what we needed to do at decentralized level, right down to a small 8-hour facility, someone was going to make a bigger cut and make a blunter decision around what the service platform needs. So we built some shared purpose, and we tried to really build a sense of solidarity, identify and manage risks together, because we know that medical, legal, and costs across the country have rocketed, but centrally we want to make sure we want to try and protect quality service delivery to clients. Next slide, thanks. People management as a core component of district health systems, but also as a big focus area for capacity development, and ultimately the people who drive the process and the interventions to try and get this system galvanized and responding to the financial threat that is on the horizon and sort of rapidly coming into view. I termed an integrated workforce management strategy for our team, where there are multiple leverages, tactics, and tools, which we can unpack almost in a separate seminar. So this is about capacitating a lot of new line managers, getting people to share good practices, but really focusing on the treasure in our system, who are our people. The people are our wealth of knowledge, expertise, and if we don't get this facet right, we are dead in the water. So it's about, by the time you are navigating around staff numbers, for the moment, we are managed through an approved post list, where there's a maximum percentage of post filled and a rand cost that is authorized for financial year. You make sure you expedite filling of this. There's coordination of leave planning. Agency staff is a really big aspect of cost drivers, because the agencies make a fortune, and often they're your own staff who are moonlighting, thus increasing risks of burnout with moonlighting and so forth. So you need to balance all these facets of your workforce. But ultimately, we've been looking at a lot of normative practices, where the hospitals within certainly my network and my colleagues' networks, they spend time benchmarking around safe staffing norms. It's not ideal norms, but they're safe as best as possible. And also in your critical areas that are constitutionally mandated, like emergency centers and MOUs. Yeah, capacity development all the time. Managing all of this is stressful for managers, so our senior managers are enrolled in coaching to help them navigate a lot of the challenges that they face in this space. Next slide, thanks. So we've got any number of tools, processes, systems, and lots of data. So I've mentioned the what we call the APL, and it is really a phenomenally useful tool, because it sets agreed parameters, and by the time you get to the middle of the financial year, people are facilities are approaching the kind of limits, and that's when the negotiation and the horse trading starts. if we are told that, well, you're over your set limit of 94.5% across a very large platform of over 20 entities, it becomes quite a thing to try and navigate, because everybody obviously wants to jockey with their particular post. So we try and look at careful monitoring and forecasting for natural attrition. We've got another key tool in our governance environment is budget monitoring instrument, where we are expecting every capacitated line manager to understand it, work with it for their own specific context, to benchmark against similar facilities. It enables very quick drill downs into our key cost drivers. And of course, we've seen phenomenal increases of security in urban settings, high-risk areas, diesel with lots of stage 6 load shedding, food inflation. So we really know the business and we turn over every penny. We use agency staff forecasting tools. We really try and get value for money in contract management, especially in security. We use other tools in supply chain, and we try and get people to do sense making around the spreadsheets and the tools so that it all kind of goes into a unified whole and they can develop strategies locally. We can improve feedback centrally, and I think we've built trust in our system. Next slide, thanks. So your clinical managers are critical for walking along, because they often are your main cost driving agents, and they need to become change agents. So if you can get a surgeon, an orthopedic surgeon or general surgeon, to really think about the implants that they're using and making sure that they're getting value for money and getting the product that is good enough for what they're requiring. If you get the family physician or a senior medical officer or a CNP really interrogating the investigations that they're doing for blood tests, it makes a difference. We have done work for years in phlebotomy practices to reduce waste. We look at evidence-based testing and protocol adherence, and we're leveraging other aspects of technology to ensure that there's no duplication across geographic areas where patients might be at a hospital one day and at a primary healthcare facility another day. There are similar interventions in other key clinical cost drivers, blood banks, medical surgical goods, and of course our medicine budgets are massive, where we really drive a multidisciplinary approach and clinical leadership for protocolized care, and using pharmacy and therapeutics platforms for utilization assessments and audits. Thanks. Next slide.
3 more minutes, Kathy.
Thank you. Governance and leadership. We have regular structured interfaces. We do check-ins. What we've seen of certainly in the last 8 months, where we've been doing cash flow management since the last financial year, the last quarter, there's been a lot of cross-disciplinary learning and understanding, so that financial managers understand the limits to which we can cut services or reduce clinical expenditure. Next slide, thanks. So the context matters, and when we are placed as health system managers under the financial cosh, the dynamics across a very diverse platform come into play, and the schisms are actually very dangerous in terms of people wanting to really draw up the drawbridge to protect the interests. And one of the biggest principles is to make sure people recognize that we're all in this together. We need to share the challenges. So yeah, the issues of the perspectives of tertiary versus district health system partners, rural versus metro, sub-districts, specialized versus acute hospitals. So there are tensions playing out in all of those all the time. You're having to figure out trade-offs and how best, where best do patients get managed. It's very difficult to manage in a multi-hospital setup for the reasons I've shared, but you need to try and seek win-win outcomes for all the stakeholders and putting clients at the middle. We need to, maybe just next slide, thanks. The district manager becomes the middle person to try and navigate those deals, but the nuts and the bolts are the impacts on the patients, and some of these are not usually immediately evident. Services get delayed, there are system gatekeepers, care gets rationed or cut in entirety, and often very quietly. Wards and theatre slates close quietly because we can't fill posts. Hasn't happened quite yet. There are sudden downshifts from tertiary hospitals, the waiting time for ambulatory care, appointments at OPD. As new clients are coming into PH, the wait lists become weeks and months. Scheduled surgeries on lengthened waiting lists and then become urgent surgeries, and thus incurring more costs. PHC facilities get asked to, use more complex and expensive tests before getting access to care at higher levels. The patient experience becomes much more difficult, longer term before definitive care. Up referrals get wait. Outcomes are not optimized if diagnostics and interventions are delayed, and the complaints rise. So there are more pressurized staff, and that really feeds into a very difficult cycle because the moral injury rises and managers stress. Last slide, thanks. This is the one. I think the health sector gets really impacted, and even if we've moved all these financial levers and done all the tweaks in the system that we've all done over many, many years, it's very anxiety provoking now to sort of be staring down the barrel of a gun. But we are doing a lot of system redesign. So I think it was referred why the loss of PHC headcount. We are shifting people into community care and wellness hubs, but maybe, and the data capture is being regularized into the system. I just want to reflect on the moral injury that we've really been thinking about when health sector resources declining in the face of rising burden of disease. We are absolutely horrified when we see governance failures and fruitless and wasteful expenditure when we know we can use that for a nurse. And the post-COVID environment, the red highlights, I think, what we are seeing playing out in our facilities and our services, in mental health, nutrition, explosion of non-communicable disease, and that coexists with patients in comorbid environments with infectious disease. And there's this the tsunami of violence against women and children and interpersonal violence. So all of this is also causing our human development index to decline. We need to keep people in work so that our economy can thrive and grow. But yeah, in closing, it's a huge impact, and I worry for my managers because we are trying the best that we can. We understand that there are differences between fiscal discipline, austerity, and budget reductions, but ultimately it plays out for patients and health system people as being a very tough environment. Thank you.
Thanks very much, Kathy, for that very, very rich set of insights. So, just a few things. The need to keep your eye on who you're serving, focus on the client, and keep that centrally. The critical importance of people management. So that's both the formal human resource management functions, if you like, integrated workforce management, you referred to it, but also how you lead. So it's management and also the incredible task of leading, of creating a sense of a collective, of common purpose, and of recognizing that these processes are very stressful and naturally lead to conflict and siloed responses and people protecting their turf. How you enlist clinical managers and clinicians into the process. And then, of course, all the the tools that the technical tools and systems that aid. So it's a complex set of system factors. So let's open it up for discussion. So are there any others in the room who want to speak about their experience, particularly those who are more at a district or managerial level in the system? So anyone want to say anything, comment? Lucy? Yeah.
Thanks very much. And thanks, Kathy, so much for that rich input. I wondered if there were critical limits on the flexibility that you have at district level that constrain your ability to respond to fiscal crisis. And I'm thinking of public sector regulations, for example, with respect to human resource management. We haven't spoken about the regulations around those things, but maybe they limit the responses that can be implemented to address austerity issues. And I wondered if there was anything there to think about moving forward. Thanks, Kathy.
So I don't see any other questions, so why don't you go ahead, yeah.
So I'm going to try and understand what you're asking me and try and frame it. So we've been told very clearly that the PFMA tells us we cannot overspend. So that's the one kind of legal framework. The Constitution is our other big legal framework where we say we have to provide maternal and childcare. We have to provide care under the Mental Health Care Act for the most vulnerable. So we're always putting the client at the center of what we do. As to whether there's a limit to which you can say we can't actually run a particular service, and that service we will have to find a mitigating strategy to counter that service, to cover that service elsewhere within the available resource budget. We are currently busy doing that. We're looking at consolidation of services, trying to understand what the opportunities are from existing growth in, for example, transitional care. And that's been a policy environment that has been growing and developing. But you do reach a point where you say you can't actually run a service safely. It happened recently with the taxi strike. We didn't have enough midwives to run a service. Then you temporarily redirect, you divert to another service point, and you locate whichever remnants of your staff were able to get to work to that particular alternative service point. But to do that on a permanent basis, you weigh up the risk of what the reality is. And if the reality is you don't have the adequate staff, you are going to have to make the tough decisions around consolidation or decommissioning of a ward or a service. And then that plays out in terms of access and outcomes. Thanks.
Yeah. And I think, I mean, if I understood the question as well, is do you feel you have enough decision-making authority if you need to do that? But let's come back to that.
So maybe I can just essentially,
briefly,
our governance systems, we would propose something and it would go through the system.
Okay. All right. So it was Thoko, Kate, then Krish. So try and be brief and just make your point or ask your question, and then we'll come back to you, Kathy.
Thanks. I just wanted to respond to that question about the sort of bare minimum. And I didn't get a chance to speak to it very much, but there's a kind of human rights and budgeting community that talks about protecting and designing the macroeconomic framework from a care economy perspective. And in terms of our constitution as well, that should be the lens that we should be using to formulate our budget. So when we are talking about fiscal consolidation measures, we need to assess them against the protect, promote, fulfill, and respect components of the Bill of Rights, and that creates the bare minimum. And a caring economy sees the social sectors as being a driver of economic activity, as opposed to seeing it as a cost to the economy.
Thanks. And Mark, I'll also give you a chance just now to also make some responding comments. Kate?
Thank you. I'm Kate Sherry from Rural Rehab South Africa. I'm very aware, just to comment in all of this, how the panic induced by the austerity plus everything else makes it very easy to shut down and kind of stifles the creativity we need. I'm not quite sure how we keep that going, how we still look for better outcomes and better strategies while frantically trying to do the impossible. I think one of my main point is really about how we make sure that the cuts that must inevitably happen don't transfer the costs to the most vulnerable. I'm thinking specifically of, for example, closing peripheral service points where the clinics, outreaches, always the first things to be cancelled. We've done quite a lot of work looking at transport costs, specifically for people with disabilities, but other people as well living in rural areas. And the reality is that as soon as you centralize a service, you transfer the cost you are saving to the poorest households. So yeah, I think my question is about how we make sure that while we're saving costs within the health service, we're not pushing more people deeper into poverty. Thank you.
Yeah. Thanks, Kate, very much. Krish?
Thanks, Helen. So Kate has covered my first point, which is, I think when we're under pressure as a system, I think there's a hyper focus on efficiency, and we don't think enough about equity and most vulnerable populations. So Kate has covered me adequately on that, but I think it's just an important point to bear in mind. The second point is the numbers that we count, right, are often things that are coming into our health service, right? So patients coming into our health service is what is counted. What is not counted is the unmet need. And there's lots of evidence for large burdens of patients that are undiagnosed or diagnosed but untreated, and untreated or if treated, poorly controlled, right? That's a huge, and there's also patients who started treatment and lost to follow-up. So there's a whole quantum of patients that are kind of off the radar screen. And I think we need to bear that in mind as we talk about what the impact is of these budget pressures on the system. And those are often silent epidemics. Like we take mental health is a good example. The estimates are that almost 1 in 10 mentally ill patients actually access care. So it's a very significant burden out there that's not counted and not often front of mind when we debate these things. Thanks, Helen.
Thanks, Krish. So, Kathy, any last thoughts from you on these questions? I mean, they were largely comments rather than questions, but...
Thanks, colleagues. Yeah. Just to reassure, while we rebuilding governance systems and trying to find maximal efficiencies, we've been redesigning services really since COVID, with home delivery. So certainly with older folk, we particularly managing to get medication out to them. We've built on that with making sure the community-oriented primary care approach really looks at local nodes of how we best use all available resources through our funded NPOs. We've set up multiple wellness hubs, which have really opened up opportunities and possibilities for reaching particularly unreachable audiences, including men who don't really come into the facilities until they're really unwell. Expanded screening opportunities, expanded health promotion, wellness interventions, doing offsite wound cares. So we've got a large project happening up in a very impoverished area, Atlantis, which is undergoing a lot of shift and change, and have seen over a period of 1.5 years how we can actually, through service redesign, decompress a really busy EC of the local hospital, which was, I think, it's the third busiest hospital in the metro and the fourth busiest EC in the province. We've been, and just through changing access to primary care, adding a little bit of additional capacity at the facility, but supplementing it with access to wellness hubs that they are expanding. So we really reconstructing a Boeing while flying. It's trying to exact as much efficiency out of the system as possible, but also really trying to future-proof our system and capacitate managers and clinicians and support staff around the transition and the transformation that we're seeking. Thanks.
Great. So managing this, these huge challenges and pressures requires an enormous amount of system leadership and governance and stewardship and creativity at a moment where people may have least emotional energy for it and capacity. So clearly a huge challenge. Great. So thanks very much, Kathy, for those great insights. Mark, I'm going to ask if you have any 30-second last reflections, and then I'm going to hand over to Uta to say a last few words. So literally 1 minute. Over to you, Mark.
Okay, thanks very much. Yeah, look, I really want to appreciate what Kathryn's input was.
Just come closer.
I really want to appreciate Kathryn's input. I think it was very clear and very logical. And I think those kinds of inputs not only are so important in steering us through difficult periods, but also in kind of speaking out words of wisdom to the decision makers. And several of the other comments, including Jenny Nash's comments and quite a number of the others, I found very, very helpful suggestions were made. I think during this period, it's very important for people to speak out, to publish, to say what they're experiencing and what they're seeing and feeling and thinking. If you look at, for example, in the UK, it's been very difficult to, for example, cut the NHS because there's always a really, really strong outcry against it. So there's a natural kind of defense of it. And I think that kind of thing is very important. I think government does make it finds it very difficult to make decisions. I think the National Cabinet finds it very difficult to make decisions. They, everything is important. And so it's almost difficult to prioritize anything. So, I think it does require stakeholders to stand up and defend the public health system
Come closer. Yeah.
Yeah, no, I think let me end there. But thank you very much. I think it's been very, very, very useful.
Okay, and also comments in the chat about sharing this more widely and creating opportunities for learning between district managers. So a big thank you to our speakers and to all of you. I'm going to invite Uta just to make a few concluding remarks. Uta, over to you.
Thanks, everybody. And yes, thank you for incredibly useful inputs. And I think also the combination of inputs we got today from Thoko, from Mark, and from Kathy were really, really useful to get the different perspectives. Now, I've been thinking quite a lot about what can the Salad Collective do? What can we as academics do in this situation? And we have been asked by some of the people, the practitioners, where is the literature that can help us steer the course of this? And I have been trying to find some literature and actually have come up pretty empty. There is not very much, I mean, looking at the British example, the Greek example, and there isn't much that talks about what were the actual measures to steer through their austerity measures. So I think that we actually have to look at this at different levels. I think there is the work that Thoko and others, Institute for Economic Justice and others are doing, that is about understanding the macroeconomic and political arguments. Are we going in the right direction? What alternatives are there in the macro picture? And of course, that's also very much Mark's work. I do think we need to understand and need to track quite carefully what the specific effects will be on the health sector, and understanding there what's happening in South Africa, but also try and follow what's happening elsewhere on the continent, certainly. And I think then we have, I think for us as academics, we have a particular role to try and to document and share the local and international experiences as we go forward. So I think that is about what are the impacts of consolidation, fiscal consolidation measures, if we don't want to talk about austerity, impacts on staffing, on infrastructure, on health worker motivation, the whole notion of moral injury. If we think about moral injury, I think it's very important that we then think about, so what does that actually mean? What are the indicators? How do we talk about that? I think there are a range of, I mean, we need to document measures, processes, impacts that are now unfolding both at national, subnational, district, community level. What's happening to changes in resource allocation? I found very interesting the thought today to say, actually, there is room for redesign, there is room for savings. Let's use the opportunity. Let's not waste the crisis, and let's use the opportunity to actually also think quite differently about some of the things we are doing. And I think then creating the platforms to actually, as we go, A, document this, and B, to share what people are doing. And similarly to what Kathy did today, I think that's extremely useful. And Jane mentioned that in the chat. Others can learn from that. Others will have different experiences in different or similar contexts. I think creating the platforms to talk about these experiences, to talk about what works and what doesn't work, to talk about the impacts and where things are really spinning out of control or getting really, really bad, to be able to pull it back. And also in documenting and sharing to then also inform the policy discussions at national level, because I think there too, it will need to be learning on the hoof to see what are measures that are particularly undermining of the growth and development, and what are measures that maybe give opportunity to increase efficiencies and improve service delivery. So I think as this collective, it would be very useful if we thought quite carefully about the process of documentation and the process of sharing amongst different audiences. And the Western Cape, of course, has the experience of the learning collaborative during the pandemic. And that's what I was thinking about. We will go into quite an acute crisis situation, although it will be probably longer lasting. So I think to create these fora in a similar way and possibly beyond this province and create a platform across provinces will probably be a good thing to do. And it is, but then also more public. Those are my thoughts. Not terribly.
Yeah. No, very, very, very helpful. And our agendas are set. So we have to try and actualize some of these things. And I think the Salad Collective is a good place to start this. So Thank you very much to AI speakers and all of you for contributing. If you feel up to it, we could just put our videos on and just say hi and bye to everyone before we go.
My is not working.
We didn't hear you, Zama. Next time. Next time
Yeah.
you will comment. We will give you a chance.
Sure.
Okay. Thanks. Hi, Harsha. Nice to have you. Okay,
Bye,
ciao,
thank
everyone.
you.
Tulani, we didn't hear your news, but I'm sure we'll have a chance next time.
Sure.
Okay, bye, everyone. Take care.
Bye-bye. Bye-bye, colleagues.